úlcera.
Supongo que vas a tratar
¿Sí?
de drenar la vía biliar ya con un stent metálico no cubierto y no vas a esperar el resultado de patología para hacerlo en base a la imagen endoscópica que
Excelente,
estamos viendo.
excelente pregunta y concepto. Metal stent, they're talking. Mira, eso es una cosa que estábamos discutiendo aquí también, y por supuesto que el drenaje de metal vale la pena. A mí me gusta más drenar con metal si es una de tipo 3, porque se mete solo un stent. En este caso tendríamos que meter varios stents en el lado izquierdo y en el lado derecho, y tendrían que tener diámetro de 6 o de 8 milímetros. No logro ver qué largo tienen la estenosis hasta el lado izquierdo y hacia el derecho. Y en estas oportunidades a mí me gusta ser a veces más conservador y poner un stent de plástico. Inclusive hoy estamos pensando dar tratamiento con radiofrecuencia, disminuir la masa tumoral. La radiofrecuencia tiene un efecto local, loco-regional inclusive, porque es transmural el efecto que tiene, y capaz que hasta le podemos ayudar al paciente a que se abran un poco más las vías biliares. Pero por supuesto que stents metálicos es una opción.
There are so many options to
Hay
consider.
muchas opciones que no están.
Yeah. For instance, this patient is anticipated to go to surgery within 2 months. So we think that most likely the risk of cholangitis with a plastic stent is probably low within that time frame.
Yes.
And it's also a question of resources. You can spend a lot less putting in a couple of plastic stents without the risk of cholangitis, especially if the patient's going to surgery. But if there's no surgical thought whatsoever, then this is someone who we would definitely put a metallic stent.
Exactly. So, si supiéramos que en realidad ya no se va a hacer cirugía en el paciente, stents metálicos sería la opción, pero aquí todavía existe la duda, y entonces vamos a poner stent de plástico y la mayor cantidad posible.
Doctor,
ya tenemos
sin duda,
otra buena
las
biopsia,
imágenes
ahora
son
estamos sacando.
extraordinarias, pero en el caso de no tener spyglass, había un cepillado para
terapia ablativa, y creo que esto sí podremos hacerlo hoy.
Three good. Keep going. So we have 3 good biopsies. Perhaps we can, if we could get the camera to focus on some of the challenges that we have. These are the
La
spy
cámara,
bites.
señor. Perfecto. Y vamos a hacer radiofrecuencia también. Después, exacto.
Yeah,
Sí, démosle.
So you can see here, if you look at the tissue, we're not seeing gigantiform. So we want to maximize this so that we don't end up with that atypical cell indeterminate diagnosis. It's almost like the first couple of biopsies are more debris and mucus.
Yes, but the next ones are
But the next
excellent.
ones end up being in the money, so as we go. That's very good. Yeah.
Y los stents plásticos, Mark, ¿a usted le gusta los tipo Amsterdam o double pigtail que se metan?
I think with a stricture like this, I like the Amsterdam. The double pigtail changes the flow dynamics of the stent, and I think it allows early obstruction of the stent.
Very good.
So the straight Amsterdams, I think, especially with a stenosis like this.
Entonces, ustedes pueden oír que Mark también es ingeniero. Él estudió ingeniería Desde el punto de vista anatómico, por supuesto, poner un stent de doble cola de cochino, ¿se llama así? Ajá. Tiene una ventaja anatómica porque se mete dentro de la vía biliar y se adapta bien. A mí me gustaba esa idea anatómica, pero desde el punto de vista anatómico-fisiológico, de drenaje,
Exacto.
los rectos drenan mejor, dice él, y eso es cierto. Así es de que vamos a poner stents así, bueno, de boomerang.
You think that's enough or one more?
I would say one more, and we're
One
going to be
more.
good. We've got five good bites
Okay.
at this point. Vamos a hacer una más.
Ah, gracias.
Doctor
Sí,
Montenegro,
a mí me gustaría hacer un estudio donde ponemos las 6 biopsias o las 8 y ver en cuál de las biopsias el patólogo hizo diagnóstico. Place all separately and see which one was the diagnostic one.
Ajaja.
doctor Montenegro,
Ahorita viene el otro.
creo que el diagnóstico es evidente, no sé
Ahí
usted
está.
qué opina.
Now, do we have
en cuanto
a
la
do we have a
imagen del
pathologist
eyeglass.
to stand by to look at these quickly? Yeah? Do you have a cytologist who can do a quick look and then tell us? No. Okay.
It's Saturday, so
Ah. Okay. Only the gastroenterologists work on weekends.
Doctor
No,
Montenegro,
nothing there in that one.
Klaus,
Ahora hay una pregunta.
sí,
¿Sí?
Klaus, ¿cuál sería el plan en cuanto a la
Sí, gracias.
radiofrecuencia? ¿Cuántas sesiones? Supongo que después de radiofrecuencia estás obligado a dejar un stent plástico y esa sería la única justificación en este paciente de dejar un stent plástico. Si no fuéramos a hacer radiofrecuencia, creo que estaría justificado dejar un stent metálico no cubierto. Entiendo
Claro.
que el planteamiento es
Eso es, y no-
disminuir la masa tumoral y en este caso, en este momento, dejarás un stent plástico por ese motivo. ¿Y cuál es,
Esa es
y cuál
exactamente
es el
la
plan
razón.
en cuanto a sesiones de radiofrecuencia? ¿Cuántas sesiones, Klaus?
Claro, en este caso, todo dependerá de la cirugía. Pero de ahí, yo pienso que si el cirujano decide no intervenir al paciente por alguna razón, nosotros en la siguiente CEPRE fomentaríamos el uso de stents metálicos,
Sí.
ya no radiofrecuencia. Claro, entonces ese está bien hacia la derecha, perfecto. Pues tenemos suerte porque tenemos ahora 2 guías del lado derecho.
Sí.
Vamos a poner 2 stents 8 French, 8.5 y después tenemos espacio para poner otro stent hacia el lado.
Sí.
Ahorita vamos a hacer el intercambio. Si me puede dar la imagen. Vamos, ya tenemos 2 stents ahora. Ya,
¿Puede poner la imagen radiológica en grande,
Vamos a
por
hacerlo.
favor?
ahora ponemos la imagen radiológica. Estamos en una buena localización.
Gracias.
So they're
Perfecto.
going to the other case.
Bueno, perfecto. Ahora tenemos 2 guías, la 025, la 035. Vamos a usar primero la 025, que es la más suavecita y la más difícil para poner stent, y después nos vamos con la otra guía. Como un también radiofrecuencia, pero cuando pongamos los stents, ajá. Antes de los stents, sí.
Antes, okay.
Pero cuando poníamos los stents, que usamos la guía delgada primero.
Are we off camera? Okay. Okay. Okay.
Ahora pasamos a la sala 2 en lo que hacemos la radiofrecuencia de uno de los 2 lados y regresamos.
Dr. Omen, it's your choice. You want to put there? Yes.
So we'll do right side.
It's easier to do it this way. Much easier.
Okay.
But only when you're going to put the wire because the air will escape now.
Okay.
Doctor Burgos, estamos contigo.
Bueno, el doctor, buenos días. De nuevo estamos acá. Vamos a iniciar el proceso de tratamiento de este paciente. Para ello se ha decidido realizar la radiofrecuencia. El doctor Mohamed Othman es nuestro especialista que nos va a explicar cuál es la técnica.
All right. So before we start, it's very important to know that there's two types of ablation. We can do the circumferential. Very nice rounded area which shows to do the circumferential ablation. What I'm showing and it shows of the scope or both the wire grab. So it's preferable to use a shorter wire. The short wire exchange would be better. So now we have the wire in and it is inside the stomach. The next step would be to put the. All right. Anytime you're going to put object in the body, you would like to use lube. You cannot use lube over here. So what we're seeing right now, this is the radio frequency probe. You don't want to put lube in the radio frequency probe. If you do that, you are going to affect the amount of energy delivered to the esophagus. So how can we lubricate it? We're going to lubricate it with water. You have water?
Ahí está la.
Yeah.
Here's your water.
Just regular water. So we'll dip it in water. That will allow it to go easily in the mouth.
How we
Yeah.
do that?
So basically, we'll dip it in the water like that, and that's it. That's all what you need to do. So no lubricant, no lube. Now we're going to get the wire, similar to what you are going to do when you have your savory. If you can just hold it here at the end. Thank you. So we'll put it in. It's like long wire exchange. The wire will come at the end. When it come at the other end here, if you can see it, now it is coming from that end. I'm holding it from the end. And we're going to gradually make circles. And your assistant can help you with that.
Okay.
Using a long wire.
No sueltes todavía el loop.
Yeah.
Okay.
It's really important to
Don't-
keep
don't
it
lose
in the mouth.
Okay.
Now you can release the wire a little bit.
Now you release the loop.
Uh-huh.
Okay.
So we're holding the wire and we're gradually going.
Okay. Do you want special position of the head when you are doing introducing?
So when we do that, it's easier to just raise the head up a little bit. And
Then you have it.
Yeah. So get the wire here. You feel it slowly going in. We're nicely in right now. You don't want to push it too much. You want to leave it around 30, 40 centimeter. I see here we are 45 centimeter. We are going to stop. Now we have the cutter in. The next step is to get the scope in. All right, for that part, I'm not going to use the cap. So take the cap out. Well, if it doesn't wanna come out,
Let
it's
me put
okay.
out the cap.
We can leave it if it is in.
There's no problem.
Yeah. So now we are going to see where is the location of our scope.
How are you going to start? You're going to start from the bottom to the end, or?
Yeah, so we'll start down up. We can see right now we are at the GE junction and we can see that our probe is slightly down. So I will hold my scope and pull the probe up. All right, one of the mistakes that happen here, that people will just pull the probe, leaving the scope will come back, then you lose your position. Hold your scope steady and then you will pull the catheter up. What I'm seeing right now, that are the gold marks. Now I know that that's the time for ablation. Now we're going to identify the GE junction and you advance your scope in. We know that the GE junction is at here. Now I'm going to advance my probe again to be around the GE junction. I know now I'm in a good position. I'm going to come out. That probe is 4 centimeter in length. We'll stop here. We'll allow it to self-size. There's two bottoms. One of them is gray. The other is blue. We will connect the machine. It's very important not to connect before you're ready. The reason is, if you connect it early and somebody by mistake press the button, you're going to start ablation. So now we are ready to start.
Okay, wait. We're ready.
So we'll go here now. And we'll have our probe. So we're going to inflate the balloon. No, I don't want it. And the balloon will gradually inflate. Yeah. Are waiting for it.
Okay, just one.
You can press it right now.
Yeah, I can press it now. Yeah, now it is inflating. Now you can see it nicely inflate, reach to the size you want, and you deliver your energy. Okay, if you have hiatal hernia, the scope or the catheter tend to go down. So then what you do is that
Okay.
the press
It's already.
yeah. Oh, okay. It's not I thought it already did it.
Okay. No,
Okay.
I'm holding the catheter.
Oh, okay. So we're gonna start. Yeah, we're waiting for it.
Okay.
So now it is very ready,
Okay, now.
and now we deliver the energy. Yeah, first time I thought I pressed it. It did not press. All right, he's feeling it right now because the energy is good. So now we're gonna assess how much we did. Our position moved a little bit, so 4 centimeter. We can see here we have a good treatment in that area. That area did not have an excellent treatment. And that can happen sometime because of the contour of the esophagus. And that's why when you will come in 2 months, you want to approach the other area, but we are going to do another ablation, and hopefully that will get it.
Okay.
So now the next step is
Dr. Rodman, do we have any consideration related with aspiration? Should we aspirate just before the procedure? Or?
yeah, so we can aspirate, but I don't see any fluid here. But if you have any,
Well, no,
any problem
yes,
with
you have
that,
to use it up. You know, it's
do you have a catheter? Do you have any? All right. So now we did that part. We can see that the end of our ablation. We may need to go down and do another one because it came up. So because this is a very long segment, so I will advance the catheter now all the way to the GE junction. A little bit more, advance, a little bit more down, slightly down, and we'll stop here. We're going to repeat the same process again. Yeah,
Doctor Burgos, una pregunta.
yeah. So now we are waiting for it to become ready, and now we're going to deliver the energy. And you can feel it that it went there. So that's around 12 centimeter segment. That probe is 4 centimeter, so we'll come up another time, all the way up. So we'll pull the catheter all the way here up, yeah, more, and we'll get the catheter just by the GE junction, and we'll get it here like that. All right. And we want to see that that's the end of the barrette, so we're going to go slightly above it so that we can get all the area. And once we are above it, we'll start the same process again, and we'll wait for it to dilate. So the balloon is still sizing right now and inflating. You can see that happen, and now we are ready to deploy it.
Dr. Altman is asking you some question from the audience.
Yes.
Are you hearing that?
No, I'm not hearing the question.
Okay, let me... Póngame el audífono.
So now we're going to repeat the same process again. We finished the first ablation, and what we're going to do right now is to remove the balloon completely, and we'll do the cleaning. So we'll get everything out together. We finished the first one.
Perdón,
You can leave it. Actually, I can clean around it when it is there to save time. So where is the rope?
what do you want? Do you know?
Cap?
Okay, put the cap. Limpiemos.
Yeah.
Y limpiemos los lados.
Doctor Burgos, doctor Fernández,
Sí, buenas.
una pregunta. del
Les
doctor
oigo para
Barreto,
traducir
por
al
favor.
doctor.
¿Escuchó?
Sí, te oigo bien.
Sí, doctor Burgos, una pregunta para el doctor Othman con respecto
I have
a
the.
qué tools prefiere para estos segmentos largos. Esa es la primera pregunta. La segunda, cuando hay un paciente con estenosis en el tercio medio que no pasa el catéter de radiofrecuencia con endoscopio, ¿qué es lo que recomienda hacer? Y lo otro, en nuestro país los segmentos largos, cuando no hay contacto de toda la circunferencia, ¿qué recomienda? Muchas gracias.
Ok, la primera pregunta no te la oí bien, vamos a trabajar las dos primeras.
Okay.
The first question that they have is, you have a stricture there. What do you have to do in these cases?
If I have a stricture.
Yes?
Well, usually it is general contraindication to do ablation for a stricture. But if I must do ablation in a stricture, I will do focal area, and I will be very careful to go with the focal probe, not with this probe.
Okay.
So I wouldn't recommend using the circumferential probe in a stricture area because you don't know, even if the soft sizing balloon, it can overinflate, and so I would rather use a focal if there's a stricture. But generally, you want to avoid doing stricture areas or ablated.
The other question that the audience have is related with this part. When you have only part of the mucosa that was ablated, should we do in the same place another ablation to cover the other place, or just move on to another area?
So we try to do that, but sometimes it's not possible to do it. So by the way, I'm doing the cleaning right now. I left the catheter supposedly in the stomach, but it came up, so we want to leave it down in the stomach. Yeah, and we clean above it. If that happens, next time we're going to come with a regular focal probe. Like you see this area here, it's ablated but not great.
Okay.
But no matter what you do, because of the configuration of the esophagus, you may not get it. Now we're going to do another ablation, and I hope we're going to get part of it. But next time, in 2 months, you're going to do a focal ablation, and we'll target all the area that was left.
Ok, perfecto. Bueno, vamos a seguir aquí con la ablación. Les vamos a dar el pase a la sala 3 para que sigan con el procedimiento allá.
Hola, estamos de vuelta. Pueden ver que las 3 guías todavía están en el árbol biliar. Ya dimos la primera sesión de radiofrecuencia y ahorita estamos dando la segunda. Ahora pueden ver, vamos a dar 1 minuto
Ya estamos con
de
usted,
radiofrecuencia. Empezamos de proximal, vamos hacia distal. Estamos dando en el área derecha y también ahora en el área común, en la bifurcación. Este paciente tiene un lóbulo izquierdo bastante grande y dominante, podríamos decir. Eso hay que correlacionarlo con la tomografía después. Y los stents, estábamos viendo las medidas e idealmente queríamos poner un stent de 15 centímetros, pero no tenemos. Entonces buscamos solución, vamos a poner un stent 8.5 que drena el lado derecho. Es un stent que solo tiene 10 centímetros, pero no tenemos problema que quede intraductal, porque vamos a después a tener dos otros stents que van a salir afuera de la papila. Ya dimos un minuto de radiolación y ahora vamos a retirar el catéter para que lo puedan también observar endoscópicamente. Pues prácticamente es como un catéter normal que en la punta tiene el dispositivo. Pueden ver aquí el metal para dar la radiofrecuencia. Ahí está. Vamos a ver ahora los stents que estén en una localidad adecuada. Bueno, y ahorita retiramos el catéter y vamos a colocar el primer stent.
Klaus, vas a colocar stents plásticos.
Ah, muchas gracias.
A ver.
Klaus,
Se había movido el micrófono. Ah, ¿sí?
Klaus, vas a colocar
Ya,
stents
ahora
plásticos.
oigo. Sí,
Que mencionabas que
vamos a
no te
colocar
preocuparía dejar el stent intraductal. ¿Dejarías un stent plástico intraductal?
uno intraductal y dos que salgan a través de la papila.
¿Pero plástico?
¿Sí? Porque de todos modos ese a la hora de la hora se puede sacar con un balón, o no es problema sacar los stents 8.5 o 7 que están dentro del ducto. El problema ahora con stents metálicos, no tenemos stents que tengan 6 milímetros, que sería lo ideal ponerlo. Entonces son stents demasiado grandes para este caso, el de 10 milímetros o el de 8 milímetros de diámetro. Entonces esa es la problemática que tenemos en este caso, que los de plástico no son todos tan largos y los de metal son demasiado gruesos.
Klaus, ¿estás trabajando con CO2
¿Sí?
o con aire convencional?
Con CO2. Estos casos sí es preferible siempre hacerlos con CO2, ya, por la duración y el confort del paciente también. Y además, cuando estamos haciendo el spyglass, no queremos que entre mucho aire a la vía biliar porque existen casos de embolia por aire. Bueno, aquí viene la prótesis, vamos a darle aquí la guía. Ahora tenemos la primera prótesis que vamos a...
And that's an especially important point in the cases of tumor, where we can have air embolism through the exposed blood vessels.
Y eso es lo que, como dice Mark, es muy correcto, que cuando hay tumor, donde hay obstrucción parcial y mucha angiogénesis, hay tantos vasos más que absorben el aire o inclusive el CO2, pero aire más que todo, que se llena en compresión en la vía biliar y hay más chance de una embolia por gas. Entonces, aquí constantemente pues siempre veo los signos vitales del paciente, viendo la saturación de oxígeno y la presión, porque esos son los primeros cambios, es un cambio en la saturación en un paciente que está estable.
¿Van a otra sala, doctora?
Bueno, ahorita parecen que van a otra sala, estamos poniendo el primer stent, pueden verlo avanzar endoscópicamente y ahora
Si quiere que jale gris, me dice.
aquí ya estamos entrando. Avance la guía un poco. Perfecto, está, ¿no? Ahí está.
So now we're successfully on the right side.
Great. Perfecto, está. Ahora puede la marca verla un poco y retirar. Fantástico, retirar un poco más la marca. ¿Y dónde está el stent?
Seguimos hablando, seguimos en vivo.
Sí, estamos avanzando el stent, pueden ver. Bueno, ahora vamos a empezar a tratar de ir a través de la estenosis.
Clau,
Tenemos que hacer manipulación con el endoscopio.
¿no dilatas antes de colocar?
¿Qué manda?
¿No recomiendas dilatar antes de colocar las prótesis plásticas?
Eso es un excelente punto y en realidad ya teníamos aquí el balón dilatador para hacerlo y era uno de nuestros planes. O sea, nos leíste la mente, pero en el calor del caso empezamos a avanzar el stent, pero la dilatación ayuda, por supuesto, y la vamos a hacer para la otra estenosis, porque ahora, como puedes ver, hay cierta dificultad ahí. Si puede retirar un poco, sí, ahora estamos avanzando.
Okay.
Y entonces ahora ya logramos avanzar, como pueden ver, ya estamos a través de la estenosis. Yo estoy intraductal, como les decía, en este caso de verdad no tengo problema porque el stent es escupido prácticamente por el tumor a veces o por la estenosis. Ahora ya lo podemos liberar, sí. Ya tenemos el primer stent del lado derecho.
And the fact that the stent is intraductal is actually less of an issue in terms of flow dynamics. It's actually going to be more protected against food debris and biofilm.
That's a very good point. Lo que importa es la dinámica de flujo. Y con 3 stents la dinámica de flujo es totalmente positiva.
Yeah.
Inclusive otras veces lo que hacemos nosotros es cuando hay estenosis que son tan complejas, especialmente en pacientes que tienen trasplante de hígado, tuvieron una isquemia de la vía biliar, ponemos stents 7 y stents de 5 French pancreáticos.
Max force.
Y la otra prótesis, ahora ponemos la prótesis larga, la otra.
La 10.
Sí, la 10 del
Por el
otro
izquierdo.
10 por 12.
Ya.
Ok, entonces esta aquí.
Esta. Perfecto. Entonces, ahora aquí, como pueden ver en mi mano, tenemos todas las 3 guías. Siempre es importante mantener la diferencia. Ahí las tenemos ahora bien localizadas. Ahora vamos hacia el lado izquierdo. Y la pregunta de Juan Manuel acerca de dilatación es muy importante. Vamos a dilatar el otro lado. El lado izquierdo lo pseudodilatamos, o en realidad lo dilatamos con el esfinterótomo y además con el catéter de radiofrecuencia ablación. Lo introdujimos varias veces en lo que estábamos esperando aquí la audiencia nuevamente, pero del lado derecho, al final vamos a tratar una dilatación. Tenemos el max force acá.
Klaus,
Pero ese punto es muy importante para la audiencia, siempre tratar de tener la máxima dilatación.
Klaus, una pregunta.
And we're hoping that with the
Sí.
En tumores biliares,
Ajá.
que técnicamente son muy complejos para su drenaje, ¿tú prefieres iniciar al lado derecho o al lado izquierdo? Endoscópicamente y técnicamente es mucho más difícil iniciar por el lado izquierdo y la recomendación es iniciar por el lado más difícil. ¿Tú qué opinas?
Sí, lo que hacemos ahora nosotros, hay unos buenos estudios de Corea donde hicieron mediciones del tamaño del hígado, viendo si el lado derecho o el izquierdo, cuál era el que tenía predominio de tamaño, y pues al ver la tomografía puede tener uno una idea cuál parte del hígado es la dominante, y esa es la que tratamos de drenar cuando hacemos la CEPRE. Y pues si son las dos que están ocluidas y en una está yendo un poco más de contraste, se mira muy dilatado como en este caso, así como lo había hecho el grupo acá, drenar el lado izquierdo fue la decisión correcta, aunque instintivamente uno pensaría que el lado derecho del hígado tiene más volumen.
No.
But here it was the
No,
good
here
decision.
it's a good decision. But I think an important point is that this patient had a stent in the
Hay
left
que avanzar.
side and had complete normalization of bilirubin. So even if we could not have succeeded on the right side, he would have been adequately drained based upon the drainage characteristics of the liver.
La pregunta es por
Espere un
qué
segundo.
en términos generales uno prefiere empezar drenando el lado más difícil y ese es el izquierdo. Creo que ahorita va a ser un poquito complicado
Claro.
drenar el lado izquierdo ya teniendo un stem hacia el lado derecho.
Esto, en este caso, el lado izquierdo, la verdad que durante el caso hemos tenido varias veces la introducción de la guía y sí la hemos logrado avanzar, pero como dices, puede haber cierto problema ahora de pasar el stent, pero pues haremos lo posible.
Well, the moment of truth is going to be whether we can get this above the bifurcation.
Claro. Pues ahora vamos. Lo que pasa es que ahora todavía tenemos la guía número 035 adentro. Avance la guía. No, avance. Avance un poquito más. Puede retirar un poco.
Yeah. There we go.
O sea, como decía la audiencia, predecible, a veces puede ser algo difícil el drenaje, pero la guía, como es la guía, la número 25, se había doblado un poco, pero no hay problema porque inclusive la podemos cambiar a una 035. A una 035.
Okay.
Entonces aquí lo que hay que hacer es persistencia y paciencia. Por eso es que a mí me gusta usar mucho más los stents que son algo más delgados. Ya pasó allá.
And we're using a series of different maneuvers, the side-to-side movement of the scope as well as pulling the scope back and forth. Helps to kind of shimmy in between the tumor and the stent.
Sí, ahora estamos tratando de avanzar. Siempre lo importante es paciencia. Además tenemos al paciente intubado, totalmente estable. En inglés decimos persistence wears down resistance.
Klaus,
La persistencia. ¿Sí?
en México decimos paciencia y salivita.
Exactamente, ahí vamos. Mira cómo exactamente ahorita ya avanzó. Perfecto, seguimos avanzando. Ya pasamos ahí Pero yo creo que esto es lo excelente de un caso en vivo de estos, ver que en realidad esto es lo que pasa en la vida real, que cuando presentamos los videos, muchas veces no dice la hora que se comenzó y la hora que se terminó, están editados. Pero lo bueno es de que, como pueden ver endoscópicamente, milímetro a milímetro vamos avanzando, podemos ver la radiología. Ahí está la guía perfecta. La guía me gustaría más si la logra irse un poco más profundo, entonces ahí vemos ahí, es una guía 0.25, entonces ahora,
Klaus, ¿te serviría
¿cómo vamos
cambiar la
ahora?
guía ahorita para que te diera un poquito de mayor fuerza para empujar la prótesis?
Excelente punto. Eso haremos. Te agradezco. Es como que estuvieras en el cuarto haciendo la endoscopía. Vamos, we will change for a 0.35.
I think
like
so.
Juan Manuel says.
I think so.
Bueno, nos vemos, pero hacemos lo que tú dices y ahora estamos poniendo la guía.
Gracias.
La 0.35. Gracias.
Estamos contigo, Herbert.
Bueno, estamos ya en fin.
White marks every way here till the Z junction. But look at that part. You can see the water accumulating here. These gravity parts is not going to be burned by the balloon. And you can see it almost looks like a pseudo diverticulum. And the more you inflate the balloon, it will go the other side. Did not burn. So overall, I would say we were able to achieve ablation of 95 to maybe 98% of the segment, with the exception of a small area. It's very important to note too that we have to only do nodular Barrett, and you would like to comment on that, the new guideline?
I
We
was
already
telling
saw
them
that,
about
yeah.
that.
Yeah.
Can you show us the magnification, the place that you ablate, just to see the vessel that you...
So that's the area that we ablate, and this is how it looks like. And we're gonna see here the blood vessel under the ablated part, which also show us that ablation is very time. All this mucosa will slough, and then will come in 2 months. So right now we're still seeing this blood vessel. I expect later on all of this will slough down.
And right there, yes,
and we
right
can
there.
show here how it goes down. You can remove the mucosal part. You slough it down like that. So, and when we come next time, all of this will be replaced with new epithelium.
Dr. Odman, one of the questions of the people in the audience was if you have a...
So elevated lesion, EMR, now showing that ballot combined with EMR or ESD will achieve 100. The worst thing can but nodule has to be really elevated. I would say nodular area at least 5 millimeter or higher in depth. That's nodule down there. You can do that, but in generally you want to avoid ablating the area that you did the EMR. You bring them in 2 months later and you do it.
The other situation that we want to... the ablation, or you just leave like that?
So there is two schools. The standard method of doing that is that you will peel all the mucosa and do the ablation. You're removing all the rich tissue and allow the energy to go. You are study showing that you can just go 2 times and they compared both methods and they achieved. They also do that. At least slough the mucosa. As you see what we did, we advanced the balloon.
¿No hace la ablación de esa zona distal que nos con la...
Explicaba que él prefería, en caso de la ablación, hacer pequeños segmentos para reducir en el paciente la sensación de dolor después del procedimiento. Y eso es una condición en cual él preferiría, en este caso, entrar en un segundo tiempo para poder hacer esa zona, pero con un catéter dirigido propiamente. Pero esa es la razón esencial donde el doctor sugiere que cuando hace uno lesiones muy grandes, usa la presencia de dolor importante para el paciente. That's right, doctor?
That's correct, yes.
The good thing is Mohamed speaks very friendly the Spanish, but he doesn't want to do that.
Yeah.
Sí, les oigo.
Me siento un poquito nervioso porque yo hago un procedimiento y no puedo hablar en español en el mismo tiempo hacer el procedimiento.
Perfecto.
Lo siento.
Te oigo.
Herbert, ahora que hizo la magnificación después de la ablación, nos damos cuenta que no es una ablación al 100%. O sea, se veía prácticamente la mucosa sin cambios. ¿Eso es algo que está descrito? ¿Es algo que puede explicar los resultados buenos o no del procedimiento?
Okay, the question is, when you do the magnification, we just see that you still have vessels there and you still have mucosa.
Yeah.
But,
So all this blood vessel will go away once this area become necrotic.
Okay.
So right now we have a burn effect. You can still see blood vessel under the burn, but once all of this become dead tissue, it will slough down.
Yeah. Okay, aquí hay dos aspectos que son importantes. La ablación es un proceso donde hay una lesión de la mucosa por radiofrecuencia que no necesariamente trasciende el momento agudo de quemar la estructura. Estamos desestructurando la base glandular. Y esto va a caer fácilmente. Ahora, los vasos que están por alrededor, entre los 80 micras, siempre se van a mantener porque es parte de la estructura de la base submucosa. Por eso es que los podemos ver. Recordemos que estamos usando una técnica que tiene la capacidad de penetración y con eso podemos ver vasos más profundos. Pero si ustedes observan, en la superficie general, los vasos del capilar subepitelial desaparecieron totalmente. Esa es una de las zonas ahí que se ve muy bien. Y lo que quedan son los vasos profundos. ¿Los ven?
Sí.
El capilar subepitelial desaparece porque lógicamente con la técnica los vasos que estaban colocados a 25 micras, pero los vasos que están colocados a 80 micras seguimos viéndolos. Lógicamente esto es un efecto residual que casualmente en la reconstrucción, cuando vemos los Barretts ya tratados, los que quedan siempre son esos vasos de 80 micros, por ser una macrovascularidad de esta. Entonces yo diría que no, que el proceso está bien realizado. Si quisiéramos tenerlo un poquito más crispy, por decirlo así, más tostadito en las zonas, podríamos tener un efecto como este, ¿verdad? Pero siempre vamos el efecto de necrosis y coagulación se da.
So for example, like here, that's a very well burned area. It is actually almost deep burned here.
But you
And
can even see the vessels.
Yeah, but you can still see some vessels. That there is a process that the necrosis has to happen too. And yes, there is deep submucosal vessels, but even the superficial one, they will not go away till the necrosis happen and the mucosa.
Una de las cosas interesantes es ver estos pacientes en términos de 3-4 meses, porque lo que uno observa es casualmente toda la estructura vascular de los 80 micras esparcida sobre la misma zona de reconstrucción del epitelio escamoso.
Doctor Barreto, una pregunta.
¿Perdón?
Sí, doctor Burgos, una pregunta de que...
Finalmente, agradecerle a Lupita y a Carlos.
Pregunta, doctor Burgos.
Vamos
Ok.
a pasar al siguiente caso.
Vamos a
Se
dirigirnos
trata de un
a-
hombre de 51 años. Se conoce con cáncer de colon recientemente diagnosticado. Fue llevado a sigmoidectomía de urgencia con realización de colostomía. Esto fue en julio del 2019. Se realiza una en este hospital posterior a la cirugía, donde encontramos una lesión de extensión lateral no granular. Se clasifica como un Paris 2A de 15 milímetros de extensión, NICE 3S, está localizada en el ángulo. Otra lesión de extensión lateral no granular de 15 milímetros, también 2A, NICE 2, CUDO 3S más 3L, localizada en el ángulo esplénico. El procedimiento. Los objetivos de enseñanza de esta detección de los pólipos, conocer la técnica y comentar los riesgos y complicaciones. El procedimiento será llevado a cabo por el Dr. Kenneth Wittmüller. Vamos a pasar a la sala 1.
Good morning. We've had an exciting morning here. I'm really excited to be with all of you this morning. Team that is assisting me, so it's always about the teamwork. Right here we have Katia, and she is a GI fellow. Is that correct? Yeah. Colonoscope. It is a 190Q focus, which is, I think, very important because when you're underwater, you can work with just the near focus because you already have a magnification effect. So if you use your regular adult colonoscope, things will be out of focus when you're underwater. So this works very nice underwater. So I've gone all the way to the cecum, and I just intubated the ileum. And by the way, it's much easier to get in the ileum when you're underwater because you're not pushing the IC valve away from you. It actually comes. So if you have the endoscopic view now, do you have it? Endoscopy? You're going to see the villi in the terminal ileum, and it's really the most beautiful view. So I have to show you this, even though it's not essential to go into the ileum. I always do, but I just enjoy the view. You see, we doctors are so busy, we never have time for vacation, at least this doctor doesn't. So this is equivalent to going to the Great Barrier Reef and doing some scuba diving underwater, right? So this is my vacation time. Do you have the endoscopic view now? Yes? No? Hello?
No? Yes.
Endoscopic view, yes? Yes, you have it. Okay, good. So I'm just stepping on the pedal, water pedal. This is through the accessory channel, and you can see the villi here in the terminal ileum. And I'm pressing on the water pump. I just switched to NBI just to show you how we can see this with NBI as well. Very, very nice. And I'm just giving the water continuously. Now, and that's because the water pump is gas bubbles that can come in through the water pump. So that's important. So this one is not ideal for this procedure. You can see that they're always I'm going to switch off the NBI right now, and I'm going to come out of the terminal ileum. And part of the reason for going in the terminal ileum is also to clean things out. You'll notice I'm in near, see at the upper right-hand corner, near focus. You'll also see how far I was in the terminal ileum. I can go really farther than I can with the endoscopy. So now, floats towards you instead of away from you. And see how it's gaping? It's gaping because I'm not afraid of the water because it's its environment. When you put gas in, it is like it's foreign to the bowel and it closes off. So it makes things actually more difficult. The sphincter of the IC valve actually will close off on you, making. I'm coming back, and I also do. You're going to say, oh, I don't. If I put gas in, you will see a little bit of the cap. But now I'm magnified. That's why you don't see the cap. I'm not going to put the gas in to show you that, because I'd like to. Still is some gas bubbles coming in. What I'm doing is of the water, and I can use it like a water hose, and I can move around. This is why the the rate, I believe, is much higher, because you can also see what's behind the folds. Not only we have the transparent cap actually float in front of you, differentially like this, kind of like a helix and circling slowly, and I'm pushing in water and I'm aspirating, and we call this water exchange. Valve just popped off, so let me just. Use still. Looking for it?
It was.
You think it was further in?
Yeah, a little bit to the right of that polypectomy
Okay.
side.
And then if
Doctor,
needed,
una
Right
pregunta.
here.
okay,
Adelante,
I'm going to
doctor.
slowly turn in here.
Can you hear me from here?
Here it is. Here it is. Yes,
Yep, there.
I can hear you. So torquing counterclockwise, please. Peter
Yes.
Kahn, yes. Okay, he's going to hold this like this for me. Give me the 15. So we just use a 15. This is small, right? So pit pattern, you know, we can talk about that as we're getting ready. I think looks to me like a Kudo 3, maybe L. I think I see some longitudinal, yeah, and some spherical. So it's a mixture of 3S and 3L. It's obviously a granular type, right?
Yes.
And it is a Paris 2A.
Agree?
Right? And so this is really tight. Okay, here we go. So it's Paris to not more than 5 millimeters above, right? So it's not a polypoid type. This is a non-polypoid type according to the Paris classification. In a moment, you're going to see the snare. Open the snare. Okay, so we've opened the snare, and we're going to take it like a lasso. Now, it doesn't matter if you take some normal mucosa with it, and then Peter is going to hold here, and he's going to do what I call torque and crimp. He's turning counterclockwise. Peter, hold.
Yes.
Make sure you got it.
I got it.
And I'm pressing down. It's floating up. You gotta, Katya, you got a loop in here. Take it out. Thank you. Now, Katya's close. Just close. Close. Yeah. Now, you'll see I can look at it, and you'll see I've got the good margins, right? Looks
Yes.
free. Looks nice, right? Beautiful. All right, now we're ready to take it off. You could use dry cut also with effect. It's off.
Beautiful.
All right, so now let's give some water and we can kind of look at the margins and make sure everything looks nice. So I just go really close and look at this. See all the little chicken skin dots, right? So that's normal mucosa. So we're done with this guy. Done. Go back because we have another.
Guys, I wanted to make the point, there is no shame to ask your assistant to hold for you. Some people go through this very complicated. You can do.
But no, you suck the polyps through the working channel. Today.
Okay.
No. So now in the interest of time, you know, I've known Angel so long, since Hamburg days, and I'm going to now go around. So I promise Angel I will behave today. Yeah, conference. But 1 second, let me. Yes, please. While I'm quickly going around. Flexure. Go ahead. Yes, I'm listening.
Okay.
Here.
You mentioned that one of the advantages of doing this immersion colonoscopy is to
Here.
sometimes
Or
when
Peter, you
get
hold.
Carmen or any
Push
sort
in.
of
See, a little bit
helps
closer.
you out to find out a neoplastic lesion.
Yeah, give me the
you
15.
have, enough with the magnification given by the water or the saline, whatever?
Yes. So the Peter,
Oh, yeah.
going to work because it contracts. Open, please. And I'm just took it off of the near focus for a moment. Push in.
Pushing
for
in,
me. Yeah.
pushing in.
Okay, this is good. Now I want to make sure that I have the left border really free. I'm going to let this kind of flop around and find out what the optimal position is. Okay, push in a little bit.
Pushing in.
Peter. Yes, thank you. There. Now make sure it floats. Close, 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 close. Now look at this. All right, near focus. What type is this, Peter? Pudo 3L?
3L,
Yeah, 3L.
It's
Not
clearly
a 4,
adenoma.
There's no disrupted vessels, no corkscrew vessels, nothing. The NBI looks very nice. Yes. See the underwater. Why would you need chromoscopy when you get views like this? Okay, so it's sort of, to me, obvious you don't need chromoscopy. Beautiful view, ready to take it off. Coming off now. It's off. Now we look immediately here to see.
Back to you.
And we look here, and I'm just going to push the tip of the scope here like this and look at the edges, right? And make sure I got it all out. You'll notice there's practically no bleeding. And the reason for that is because the plane of resection is more superficial to the muscularis propria. So when Peter does ESD, I'm sure he's looking at MP. I don't like to look at MP.
Right.
I like to look at submucosa. It's the deep SM3 layer, but you can see everything looks very nice here. Now, just to show you how it looks there, put the air on. Normally, I don't give any air, but just to show you for comparison, because you're going to see this what looks like a fairly small area become very big. All right? So now we're going to take off near focus.
Is your audio working?
And by the way, guys, this fat in the submucosa, that's normal. Don't be scared. The fat in the submucosa. You can appreciate, some people get scared because they think there is a perforation and...
Could you please tell me whenever you have an audio? Kenneth?
I'm sorry, I have audio now, yes. I have audio. So I'm giving air, I'm sucking out the water. And then this is the polyp here.
My question was
about the chromoscopy.
Was attempting to find out.
So I don't have audio.
Can you ask him about the clips and the clips?
Yes, there is a question whether clips should be used in this case.
I don't use clips, and I tell you for two reasons. I don't think the studies have shown necessarily that it's going to significantly reduce the bleeding risk. If I see a big vessel, like here, I'm going to actually coagulate this vessel with a hot biopsy forceps, just a hot biopsy. You see the vessel right there?
Yep.
So I'll do that. I could put a clip here, but I tell you the disadvantage of clip is you could bury any residual, even one cell at the margin. If you put the clip, you may bury it in the depth. Then when you do your surveillance, you may not see the recurrence. So I don't use clips generally for such lesions. I will use it if I have a patient who has coagulopathy, right? Bleeding wrist, bleeding diastasis, yes. So now hot biopsy forceps would just cauterize this.
Shouldn't you have been such a small lesion?
Yeah.
Cut in those two lesions that you've just done.
It's already there, just to be on time.
Should you use cap? Always use cap.
Cold snaring, cutting.
Do your lecture.
Cold snare? Oh yeah, I use cold snare for small. So someone's going to take over for me because I have to go give a lecture now. Okay.
Yes. Can you?
Wow. Sí. Perfecto, estamos al aire, estamos tratando de pasar, ya dilatamos como había dicho Juan Manuel, pero todavía la estenosis es bastante fuerte, estamos pasando la guía número, el stent número 10 y no quiere pasar. Idealmente hubiera querido poner un 8 o algún 7 y pues miren ahí cómo se queda presente la estenosis y estamos dándole aquí poco a poco. Pero está prácticamente ahí que no se mueve.
We're now at the proximal portion of the
Está en la parte de la estenosis. Ahora haciendo todas las maniobras posibles, pero está verdaderamente recalcitrante, y eso que dilatamos bien con el max force, porque si no lo que vamos a hacer es poner uno que sea más, un 8.5, pero vamos a... Ahora avanzó un poco, ¿no?
Si quieres, terminamos transmisión aquí y pasamos...
Perfecto, entonces ahora terminamos la transmisión acá para mientras y pasamos al otro caso y después a la presentación de Kenneth.
Klaus, felicidades, es una situación de diagnóstico.
Aquí lo lograremos dentro de poco.
Lo va resolviendo bien, paciencia, paciencia.
Ready?
Vamos a pasar a la...
Can you hear me okay? Perfect. And do you have this now? So.
Yes. No, we don't see the slide.
So tell me when you
Okay.
have the first slide. Let me, first of all, I want to thank the organizers. My special thanks to Angel Reyes, my longtime friend of more than 25 years now, Angel. It's more than 25 years. So we go way back to our Hamburg days with Nib Sahendra. Also, my thanks to the team here at the InCan Hospital. They've been fantastic. So I'm going to talk about underwater EMR, or what I call UEMR. Do you have the slide now? So this is a good opportunity to reinforce what you just saw live with some theory, so that it explains the rationale and how I came up with the idea of doing the resections underwater. So you have the picture, okay, the slides. All right, so when we do use conventional EMR, we perform a submucosal injection before we do the resection. This has become the standard of care around the world. And why do we do submucosal injection? Well, when we give gas into the lumen, we will distend and thin the wall. This will then flatten the lesion, so it will make it even flatter than it already was. We do the submucosal injection because it will facilitate the lesion capture, it will reduce the risk of perforation, and it will reduce the risk of transmural burn. Now, these are all purported advantages, right? These are not necessarily proven advantage, but this is the rationale for doing submucosal injection. There is no proven benefit of submucosal injection by clinical study, so there's never been a randomized controlled trial proving that submucosal injection makes EMR safer. All we have is actually this one animal study with 6 swine. And this study actually was controversial, or was not really conclusive, because when they used the heater probe and APC, there was an advantage in terms of protecting from deeper thermal injury after submucosal injection with saline. But when they used the hot biopsy forceps or the bipolar probe, the gold probe, there was no advantage. So even the results here are mixed. But this is the study that's always quoted as, quote, proving that submucosal injection has benefit and protects against complications. The clinical reality from our day-to-day practice is that submucosal injection may sometimes make the snare capture more difficult. I'm going to start running this video here showing you a lesion and how we're injecting through the lesion to raise this flat polyp up. So we may get distortion and narrowing of the lumen, we may displace the lesion, we may get paradoxical flattening, but we also increase the tissue tension. When you increase the tissue tension, that is to say, we are decreasing the compliance of the tissue, then our snare tends to skive off. It slips off as we're closing our snare over the lesion. And you're seeing that here. We're starting to have some bleeding, so we try to go to a neighboring area, and this snare continuously slips off. And the reason why is because we've really flattened everything, not just the polyp, and we've increased the tissue tension in the submucosa. So again, repeated attempts, trying maybe to suck a little bit to capture the mucosa, and the snare slips off. So finally, we have to resort to salvage APC. And this is why in the old days, we used a lot of APC when we were not successful at resecting with the snare. We had bridges or we had islands. And we know today that when you use APC for this purpose, that there is a very high risk of recurrence. The submucosal injection may also be misguided. because it's a moving target. There's peristalsis constantly, and your needle tip is moving between planes, and this may increase the risk of the EMR. So if you inject into the layer between the circular and the longitudinal muscularis propria, then you may actually raise the circumferential muscularis propria, and you may capture this layer. So the longitudinal layer may still be intact, but you have come much closer to perforation now. And this is why sometimes in the report after EMR, the pathologist reports that they see muscle, and yet when you did the procedure, you didn't have an obvious perforation. If you inject outside the serosa, so outside the bowel wall, then you may actually inject into the peritoneum, and you may get local peritonitis or even probe that I accidentally discovered that when you use water submersion, the muscularis propria stays round and it does not follow the involutions of the mucosa and the submucosa. You see the muscularis propria with the yellow arrows on the outside. You see that even though there's contractility, there's peristalsis, that muscularis propria is round on the outside. So really what you're capturing is just the mucosa, and the submucosa stays on the outside. And when I saw this, that's when the light bulb went off that we actually could just resect very safely without submucosal injection. If you look endoscopically, you get this floating effect, right? You see the appearance on the left with gas, and you see then after water submersion, what 2A lesion starts to look like a 1S lesion. It is floating up. It looks as if you had done a submucosal injection, and of course you did not. Now, why does the submucosa float? Well, it's the anti-gravity effect, of course, but it's also the fat in the submucosa. So fat floats, and the submucosa has a lot of fat. And we know that from EUS because the submucosal layer, that's our third layer, is echogenic. It's very bright, and that's due to the fat, and you see that on the EUS on the right-hand picture. And on the endoscopic view on the left, you see the yellow fat in the submucosa. So we can perform UEMR without submucosal injection. The gas view on the left side pairs 2A LST with the lumen distended, underwater view with the lumen contracted. So this lesion actually now starts to look smaller because it's contracted. Then we have the snare capture with our snare, just as you saw me do, and then the appearance after EMR with the gas view. Now this is just to illustrate how the lesion contracts, and this is very important because it actually enables us to remove lesions that may in fact be much larger than our snare. So we used a 15 millimeter snare in our last case, but this lesion maybe was 20 millimeters, right, by its measurement, but we still could get it. Now I do diathermic markings for these big lesions underwater. It makes nice crisp dots. Like to use APC. And now you see how with the water, the lesion floats up, it contracts, and we wait for it to contract sufficiently with maybe some gentle suction of the water, right? It doesn't red out because it's a very incremental suction, and then we snare it off. And you saw there how you see the submucosal layer beautifully, no bleeding, and it looks as if you had done a 2-hour ESD. So this is the appearance with the scar tissue on follow-up at 6 months. This is another example of an SSA. So these SSAs, as you know, often have mucin caps on them, and they can be hard to detect. So you see that mucin or mucus cap. This is the underwater view, but note how everything contracts, and you see sort of that hairy appearance of the mucin, and you're going to wash that away. And the water helps you wash it away. Now this is the appearance after that mucus has been washed off. This is the MBI view. And with MBI, when you use near focus and magnification from the water, you can very precisely identify the transition of thermic markings underwater. We're making very crisp dots around it. So there's no need for chromoscopy or any of this. You don't need to do a submucosal injection with dye to see the margins either. Now this snare has been opened, and the same method applies where we just let it contract, and it literally, with the torque and crimp technique, we're allowing the lesion to float up into the snare. We close the snare, and we get an en bloc resection, just as you saw me demonstrate. And we can look at the margins now. You'll see the same appearance of the submucosa. This is the SM3 layer, but it's above the muscularis propria, and there's no bleeding. And this is the appearance at 6-month or 7-month follow-up. We always biopsy the scar. We get 6 biopsies because there have been reports of recurrence even with a normal appearing endoscopic appearance. So here are the biopsies that we obtain always on our 6-month or 7-month follow-up. Now, this is a paper I published already a few years back, basically just a proof of concept that we can do en bloc EMR for these very large lesions that are greater than 2 centimeters. So these are all lesions between 2 and 4 centimeters, 52 patients, a medium size of 3 centimeters, and our en bloc resection rate was 55%. Now bear in mind that even though technically en bloc was only 55, really the piecemeal was just to remove the margins. I have some artifacts, so I'm going to take this out of my ear. So the margins may have some residual, and we use a small snare to get that. So the main lesion has always been resected with a large snare. Our recurrence rate was 5%. So 5%, I think, in my book, is very, very acceptable. Our adverse complication rate was 4%, and we had no perforations with these very large lesions. Now, the ESGE recommends that we not perform en bloc resection for lesions that are larger than 20 millimeters. So I think that these type of results challenge that, but obviously this may apply when you use gas, but if you use water, maybe we can modify these recommendations and we can go Dr. Rapisi's group, and showing 10 studies, 508 lesions, the en bloc resection rate was 57%, compiling 10 studies from different centers who, as you know, are the pioneers of ESD. So you'd think there might even be a conflict of interest to 20% versus 44% with conventional. And if you only looked at the adenomas, the recurrence rate for UEMR was 10% versus 45% for conventional. So obviously what we need is a randomized controlled trial like this. Now, the risk of seeding. We are concerned about this as endosonographers when we do FNA. And we know that FNA is well documented, seeding from FNA is well documented. It's a known risk. HCC, that risk may be as high as % after FNA. And for cholangiocarcinoma, it is now that many if a prior, because peritoneal seeding is so high. So it's to say that seeding, and now we're not doing FNA, we're doing the opposite. We're injecting through our needle. So why would we not be even more concerned that we are disseminating dysplastic or maybe even cancerous cells into the deeper wall layers? And could this recurrence rate that sometimes baffles us because things look so good after we did our EMR and yet recurrence occurs? Now finally, in the last couple minutes here, just to mention that I have found UEMR very useful for these defiant polyps. Recurrent polyps, polyps at the appendiceal orifice, at the IC valve, and at the anal rectal junction. Angel is right across from me, so Angel, do I have a few more minutes or should I wrap up? Others who have become This is a study actually from Stanford University, from Shai Friedman, and a rate only 10%. The video shows you an example of scarred lesion after a prior, or actually prior attempts at resection. So it's very scarred. You can see that. You can see the whitish blanching of the area around it. Now let's exchange for the water now. So this is an air-water exchange. And already, despite the scarring, you see the lesion is starting to float. So we're going to use our 15 millimeter snare, because it's not that large of a lesion. We need to use a stiff snare for this. And you use the crimp and torque and crimp technique. And torquing means you torque it to maximize the tissue capture, the real estate that you can bring into the snare lumen. And now you close. You can see we have it. You can inspect to make sure that you have the margins, and then you apply current. The risk of perforation is probably lower for these lesions because you have scar tissue that's actually protecting you. And now you can see after the resection that we have very clean margins. This is the cork board, and honestly, you could sell this for ESD very easily, right? So I have one more example to show you, which is the appendiceal orifice, which I have found to work just marvelously because at the appendiceal orifice, the orifice inverts, and I often discover polyps in the orifice that are missed on conventional normal gas colonoscopy. So now underwater, you see how this otherwise very flat lesion starts to appear more polypoid, right? And so the diathermic markings are occurring now. You see that. I do this also underwater. So I try to avoid, and because I don't like between air and water. So now the snare opens, and you can see this open here. This is a duckbill snare, so it works very nicely because it's much more round on the left edge. And by pushing down, you allow the tissue to float up more, right? So there are all sorts of little tricks that you learn to maximize your tissue capture. And then gentle traction. You can even peristalsis. I don't like to give glucagon or Buscopan because I like the bring the tissue into the snare. Lesion, there's still some residual, and that looks like some residual. So now we're just going to place the snare, push in, and then what's inside comes out. Water, we don't need to be afraid that we're going to water structures. And then we snip that off, and now you're going to see the actual appendix. There's no residual there. It looks very clean, and this is the appearance at 5-month follow-up. Now, there is a risk of appendicitis in theory, although I'm not seeing that. The only cases of appendicitis that I've actually seen are the cases, done a few of those, and I have had 2 cases of appendicitis afterwards that had to go. One more case. Can I show one more? So I historically have gone the IC valve. Hence, our microbiome, which is sterile, is why it looks so bulky. Sometimes we think snare is open. This is a 33 millimeter snare. Is on block. Need to start. You'll see that have to coagulate. You are going to see the C that litol a list of some of the tips. Snare. Sometimes you have to call it piece. Ask. Then why switch to gas? long hours in the endoscopy lab.
Haremos puntuales a la pequeño error de impresión en el programa.